Good afternoon and welcome to today's webinar, Suicide Prevention, Building a Better Risk Assessment. My name is Jennifer Trujillo and I am the Substance Use Disorder and Special Populations Program Manager. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to health centers and community partners to improve access to health care for all, especially for the underserved population. For more information, visit us at nvpca.org. This training is a partnership between Nevada Primary Care Association and the Columbia University New York State Psychiatric Institute. I just want to take a moment to thank them for helping us coordinate this session. Before we get started, I would like to go over a few items so you know how to participate in today's event. During the presentation, please make sure to mute your phone or computer so that we don't have feedback or background noise. Also, please be sure not to put your phone on hold or we will hear your hold music. You will have the opportunity to submit your questions to today's presenter by typing your questions into the chat panel. You may send in your questions at any time during the presentation. Questions will be collected and addressed during the Q&A session at the end of today's presentation. Today's session will be recorded and slides will be available to participants. I would now like to introduce today's speaker, Adam Lesser. Adam Lesser is a licensed clinical social worker, assistant professor of clinical psychiatric social work in the Division of Child and Adolescent Psychiatry at Columbia University Vagos College of Physicians and Surgeons, a lecturer at the Columbia University School of Social Work, and the Deputy Director of the Columbia Lighthouse Project at the New York State Psychiatric Institute, where he is responsible for all suicide prevention activities related to public health, the implementation of the Columbia Suicide Severity Rating Scale, C-SSRS. He has published, presented internationally, and consulted to state and local governments on best practices for suicide risk identification and prevention. His work has been featured in Social Work Today magazine and on Atlanta National Public Radio, CNN Espanol, Univision, and other local print and television media outlets. Please help me welcome Adam today.
Thank you very much. Thank you. I'm glad to be here. I'm going to talk with you for the next 45 minutes or so about the Columbia Suicide Severity Rating Scale, and I'll talk to you about its development, why it's so important, how it's helping, and then some nuts and bolts about how to go ahead and use it. Before I start any training that I do, though, I always remind people that suicide is not always easy for us to talk about, and it impacts all of us in many different ways. Some of you on the call today may be survivors who have lost a family member or a friend or a colleague or a client to suicide, and some of you may be survivors of your own suicide attempts. And so I want you to make sure that you do something nice this weekend for yourselves to take care of yourselves, because we don't often spend enough time and attention on caretakers, and it's really important that we do, so that we don't burn out in this difficult field that we work in. So suicide, we know, is a global public health crisis. Nearly 1 million people die around the world every year from suicide. It's responsible for more deaths than natural disasters, war, and homicide combined. It kills more people in the United States than car crashes. Yet we see all kinds of public service efforts to prevent car crashes, places where you can pull off the highway to text, campaigns to wear seatbelts, but we don't see that for suicide. And that's why Thomas Insel, the former director of the NIMH, calls it the under-recognized public health crisis, because it's not getting the attention that these other causes of death get. You know, it's the #1 killer of teenage girls across the globe, and the second leading cause of death among youth and young adults between 13 and 35 here in the United States. And we've actually, unfortunately, seen a large increase in the last 5 years in the rates of suicide for our youngest victims, our kids in the 8 to 12-year-old range. Now, we know about how common suicidal thoughts are because the Centers for Disease Control does a study every other year called the Youth Risk Behavior Survey. And what they show us year in and year out is that it's about 7 to 8% of your average high school students will attempt suicide every year. So if you have a typical classroom of 30 kids, it's likely that 3 of them will attempt suicide, 2 or 3. And usually it's 2 girls and 1 boy, because girls attempt twice as often as boys do. But boys actually die, boys and men die 4 times as frequently as girls. And there are a couple reasons for that. The first is that boys tend to choose a method that's much more lethal the first time they use it. They tend to choose a firearm or hanging. And girls tend to choose overdoses with medication. But the other thing is that there's still a larger stigma for boys and men to ask for help. We see many more girls who are coming to the counseling departments and being willing to participate in services. And, you know, there's actually also a strong relationship between suicide and school violence that we don't often talk about. When the Safe Schools Initiative was undertaken by the Secret Service, they determined that almost 80% of the school shooters in their study had a history of suicide attempts or thoughts prior to the attack. And just over a quarter of them said that suicide was their motive, and that they were trying to make a name for themselves, get publicity, get revenge, those kinds of things at the same time. Yet only a third ever had a mental health evaluation, and only 17 were given any kind of diagnosis. So we're not finding these folks before these horrible things happen. Now, while we lost 45,000 adults to suicide in 2017, deaths by suicide is really just the tip of the iceberg. So for those 45,000 deaths, we actually had almost 1.5 million attempts. We see about 25 attempts to every single death. And about 16.5 million adults in America seriously consider suicide every year. So the numbers of people making attempts and thinking about it far outnumber the people who actually die. And one of our jobs and how the Columbia is being so helpful is in identifying which ones of those folks who are having thoughts are most likely to go on to making attempts and possibly making lethal attempts. Now in Nevada, you have the 11th highest rate of suicide in the U.S. In 2017, 329 of the 508 gun deaths in Nevada were suicides, about 65% of your gun deaths. And since 1999, you've averaged about 64% higher than the U.S. average. 1 out of every 4 suicide deaths are veterans. And as far as the methods used, most men use a firearm, almost 60%. Most women use overdoses and medication, and just over 40%, with about half on average of your total suicides being firearm. And as far as where suicides rates are the worst, the darker blue areas in this map are where the suicide rates are the highest in Nevada. The lighter area in the south and in the southwest area have the lower rates of suicide. And as far as Nevada high school students, back in 2017, when they did their last Youth Risk Behavior Survey, they surveyed about 1,400 high school students. About 22% of the girls and 12% of the boys said they seriously considered suicide in the last year. Almost 10% of the girls and 5% of the boys, for an average of about 7%, like the rest of the nation, said they made a suicide attempt. And 13% of those kids in the survey self-identified as lesbian, gay, or bisexual. And of those students, 20% made an attempt and 40% seriously considered it. So one of your largest at-risk groups are your LGB high school students. Now, you don't have to have a mental health issue to have suicide be an issue. It actually affects just about any kind of medical illness that you might have. So one study took a look at cancer patients and found about 18% had suicidal thoughts independent of any depression. And a recent study proved that so if you have any of these disorders, back pain, brain injury, cancer, COPD, epilepsy, migraines, sleep disorders, you have an increased risk for having suicidal thoughts and making suicide attempts. So it's not just in our psychiatric centers that we need to be paying attention and looking for these folks, but in any medical practice, which is why talking to primary care folks is such an important thing for us to be doing. Now, we actually see high risk of suicide wherever we see people doing high risk, high stress jobs. And so it's often the number one cause of death in our first responders. We lose more police officers to suicide than we do to crime, and more firefighters to suicide than we do in fire. We're definitely losing more soldiers and military personnel to suicide than we are in combat. But even in jobs like working in corrections, it's often the number one cause of death of those folks who are incarcerated and those folks who are guarding the folks who are incarcerated. Now, while the greatest numbers of suicides happen in our cities, the greatest rates of suicides happen in the rural parts of our nation. And there are a couple reasons for that. The first one being that in the rural parts of our nation, we tend to have populations that are spread out across a great distance, and that often gives us poor access to medical care or mental health care when we need it. In some places, it can take 45 minutes or an hour to get to the closest behavioral health care provider. Before I came to Columbia to work with the C-SSRS, I was the director of youth suicide prevention for the state of Georgia. We had a lot of rural counties, and we would see that when families were struggling, they, were trying to just barely make ends meet. They didn't, use all the gas it took to take their kids across the county to get to their mental health appointments. It's low priority at that point. The other thing about the rural parts of our nation is that if you look at all of the demographic factors about suicide and compare them, the one demographic factor that most closely tracks with suicide rates are rates of gun ownership. So the more guns you have in a community, the more suicides you have, regardless of any other variables that might be happening. And so this bottom map is actually a look at rates of gun shops in communities, and the top map are rates of suicide. And you can see that the dark purple areas in the bottom map tend to correspond with the dark blue areas in the top map. And this is a collection of data that makes that point very dramatically. This is a look at the states with the highest rates of suicide, comparing them to the states with the lowest rates of, the highest rates of gun ownership, and comparing them to the states with the lowest rates of gun ownership. And when you do that, you have a group of states with guns in just over half the homes, and a group of states with guns in 1 out of every 5 homes. And when you look at those numbers, you see that non-firearm suicides are roughly equal for both groups. A little bit fewer for the men in the group with high rates of ownership, 8,100 compared to 8,700, 3,500 women in both groups. But the firearm suicides that happen in addition to those are 4 times as great for the men, 16,000 compared to just 4,000, and almost 10 times as high for the women, 3,000 compared to just 300. And so just living in a community where access to lethal means is so prevalent and guns are so available, you increase your risk for suicide. Now, this is new, but not very surprising. A large portion of our opioid overdose deaths are suicides, and they don't always get identified as suicides by coroners or medical examiners. And it makes a lot of sense when you think about it. Often chronic pain gets people involved in opioid abuse, and chronic pain we know is a risk factor for suicide. And someone using opioids also may be self-medicating a mental health issue. They may have anxiety or depression, and they might be using illegal drugs as a substitute for getting the treatment that they need. And, as a result of the opioid epidemic we have and the high rates of suicide in middle-aged white men, we've actually seen the average length of life of Americans as a total decline for the last 2 years compared to every other developed nation in the world where it's been on the rise consistently. And, we used to think that suicide just impacted, the 4 or 5 people that are in somebody's family. But it's actually thought now that every death by suicide actually touches about 135 people. There are strong ripple effects that affect lots of different circles of people that, have had contact with that victim. Now, of course, you know the biggest cause of suicide is a heritable, treatable medical illness called depression, which is caused by changes in brain chemistry. Depression is actually on its way to being the most debilitating disease in the world. It costs the world about $1 trillion a year, and it's already the most burdensome disease in middle and high income countries. Unfortunately, people who need treatment for depression and other mental illnesses aren't getting it. Well, while most people with a mental health issue do not get suicidal, 90% of those who die from suicide do have an untreated mental illness at the time of their death, and 60% of that's depression. But it's estimated that somewhere between 50 and 75% of people who need treatment get no treatment or inadequate treatment. 8 out of 10 adolescents and college students who die from suicide never got any kind of consistent treatment prior to their death. And a recent study out of Georgia showed that high school students who have made suicide attempts are actually 2 to 3 times less likely to ask guidance counselors or teachers for help when they need it. And a lot of that has to do with the stigma that I talked about earlier, especially with men and some cultures. There's a great stigma in asking for help or admitting that you have a mental health issue that needs addressing. So there are a few myths about suicide I want to go over before we get into the actual scale itself. The first is that if someone's really suicidal, they're probably going to kill themselves at some point, no matter what you do. You can't stop someone who really wants to kill themselves. We know that this is false because multiple studies have shown that more than 90% of suicide attempt survivors, including people who make very lethal attempts and survive them, will not go on to die by suicide later in their life. Remember, I told you there are 25 attempts to every 1 death, so most people making attempts don't die by suicide. Most people are suicidal for just a short period of time. It's one of those symptoms that comes and goes with levels of stress. So if you help somebody through that peak time of stress in their life, they may never become that suicidal ever again, and you may actually make a lifelong difference for them. Asking a depressed person about suicide may put the idea in their heads. We know that this is false. Research over the last decade has shown that when you talk about suicide, you do not increase the risk for anybody actually going out and doing it. Some people still worry if we talk about it, it's going to happen, but that's absolutely not borne out by the science. Even when we screen thousands of high school kids, we don't see an increase in the thoughts or behaviors in that school. If somebody has been thinking about it and you bring it up, it's not going to make it worse for them. They're going to feel relief that they can talk to someone about it. And if they've never thought about it before, asking about it's not going to give them a new idea. Someone making suicidal threats won't really do it. They're just looking for attention. We know that this is false. People who talk about suicide, even people who talk about it frequently, which happens often in folks who have borderline personality disorder, we do need to take it seriously because, just because it's someone who may have this wish to die that just doesn't go away and stays constant for them, sometimes if we don't listen to them when they say these things, they will feel like they're being not heard, and they may go on to make an attempt because it may make them feel, hopeless. So we need to take all kinds of, statements about suicide seriously. There's no point in asking about suicidal thoughts. If someone's going to do it, they won't tell you. We are often very happily surprised by how honest people are on these kinds of questionnaires. But it makes a lot of sense when you know that most people who are suicidal have ambivalence about that suicidality. What happens in the human species is that wish to die that they're having is fighting up against the human instinct to live, and that causes quite a lot of ambivalence. And it's why we see contradictory behaviors or statements often in people who are suicidal. I heard about a man who had made a suicide attempt, but also booked a family vacation. So he was thinking about something positive in the future at the same time that he was thinking about suicide. And that's why we see about 80% will give some kinds of hints or warnings to friends or family, even if they don't talk to a therapist about it. Most of the time when we do a psychological autopsy after a death by suicide, we see that there were lots of people who knew lots of little things, but nobody just put those pieces together in time to be able to rescue the person. And, we know that people want to be asked because they tell us that. We do a lot of work with a guy named Kevin Hines. Kevin, if you've never heard of him, you should Google him and listen to his story. But Kevin is a survivor of a suicide attempt jumping off the Golden Gate Bridge. It's lethal 99% of the time. He's one of only 5 survivors, I believe, that can still walk after numerous reconstructive surgeries on his back. And he tells his story. He was a 19-year-old adolescent with a psychotic depression. His voices were telling him he had to die. But he made a pact with himself that day, this is the ambivalence, that if just one person asks me what's going on, I'm going to tell them everything and I'll get some help. And so he gets on the bus and he's crying the whole way there, and nobody wants to look at him or sit next to him because he looks weird. He gets to the bus driver shoos him off the bus, says, "Come on, kid, I got more stops to make, you got to get off." He walks up and down the bridge 2 or 3 times. Nobody says anything. Finally, he's approached by a woman, and he thinks, this is it, I'm going to get some help. And what she says is, "Will you take my picture?" So he takes her picture 4 or 5 times, gives her back the camera, and then jumps. And he says, "I instantly realized everything in my life I thought I couldn't fix was fixable except for what I had just done." And he instantly regrets his behavior. And what he says now is that most people considering suicide want someone to save them. And we need a culture where we're not afraid to ask and talk about these things. And then if you stop someone from killing themselves one way, they'll just find another. This is the argument for means safety or means restriction, which is actually the most evidence-supported prevention method that we know. And what that is when you put a little bit of extra time in between somebody who is acutely suicidal and them having the access to a lethal means available to them. And so since we know firearms are lethal 85% of the time that they're used in an attempt, that's one of the most important lethal means that we can try to secure when somebody is actively suicidal. And we have lots of examples about how making it just a little bit harder to get lethal means actually saves lives, brings down suicide rates. So in the United Kingdom in the late 50s, they used to use a very toxic coal gas in their stoves and had a high carbon monoxide content. People were dying by asphyxiating themselves with that gas. That's where the expression "put your head in the oven" comes from. And so in the late 50s, they started phasing it out, replacing it with gas like we use. And they were able to cut their carbon monoxide poisoning rates by 1/3 without seeing much of an increase in other methods. So when people couldn't do it that way, they didn't then think of another way to do it. It gave time for that ambivalence to work, and then many of them changed their mind. Then in England in 1998, they were having problems with Tylenol overdoses. And so they passed a law where they have to sell Tylenol there now in blister packs, where you punch the pills out one at a time from a foil-lined pack. And when you do that, and it takes just a couple extra minutes to get that lethal handful of Tylenol, they were able to reduce Tylenol overdoses by 44% over the next decade. Right? In our country, we buy Tylenol in bottles of 500 that we get at Costco or BJ's, and that's what I have at home. We don't have in our country the same efforts at making it a little bit more difficult to get lethal means. And then lots of examples about how changes to gun practice actually saves lives when it comes to suicide. In New Zealand, they passed a mandatory lock law in 1992, and they reduced youth suicide there by 66%. In our country, 85% of youth who die from a firearm suicide use a gun that a family member owns. And then in Israel, in the military in 2006, they passed a rule there where when their military personnel go home on the weekends, they can't take their guns home. They have to leave them on base. And when they did that, and they don't have their guns when they're feeling stressed out, dealing with their families and financial stuff, they were able to reduce the suicide rates by 40% in their military, just by making the access to their firearms more difficult on the weekends. And that's why we work with the firearm community, because we know that 2 out of every 3 gun deaths are suicides. Most of these suicides can and we want to prevent them. Even gun owners and gun store owners want to know how to identify this kind of risk. We're working with a New Hampshire gun shop, and the gun shop owner said to us, I don't want to sell someone a gun and find out on Monday that they used it to kill themselves and left, a widow and, 2 fatherless children. he says the guilt is tremendous, and so they're happy to have these kinds of questions, to have these posters that we've made that they can put up in their shops. But it's not just guns. We need to get this message out wherever people access lethal means. So we have a program that trains pharmacy students how to ask the questions. We've trained transit workers in our subways, anywhere where someone might have the opportunity to intervene. Now, we used to use a very medical model approach to preventing suicide, and we would train medical providers, therapists, counselors, doctors, how to identify and treat. But as you learned earlier, the problem is that most people with mental health issues aren't getting treatment. And so we believe now we need to take a more public health approach to this issue, and that means targeting a whole community. So, when we have a whole community that wants to participate, it means giving this information to all the teachers and all the community counselors and all the religious leaders and first responders, and even parents and students can learn how to ask these questions to each other. And we learned this from the Marines. The Marines were the first military division that came to us and asked for help about 6 or 7 years ago. And when they did, they didn't ask us to train their mental health folks or their healthcare providers. They asked us to train their lawyers and their paralegals and their financial aid counselors and their chaplains, because they told us that the event that most often precipitates a suicide of a Marine is having a legal problem. So they get arrested for a DUI or a domestic violence charge, and they're making suicide attempts because of the impact that is going to have on their careers. And so every time a lawyer meets with a Marine, the lawyer asks the questions. And the Marines reported a couple years ago that they had a suicide reduction of 22% after going through this process of training all of these support workers. So we really believe that everyone everywhere can and should ask these questions. The medical professionals aren't always there when the crisis is happening. And so when we train in a school, we train everybody from the principal on down to the bus drivers. And we're about to have a VA stand down where every VA non-medical employee will get a short training on these questions as well. And now we have these community cards that you can download and print from our website, which can be handed out to parents or to students or to teachers, and they remind them that they can ask these questions. And on the back, they have the short screener. They have the 6 questions, and it very clearly shows them, if any of these 3 questions are yes, you have to immediately escort somebody to get some help, and we'll talk about those questions in a minute. So the Air Force has done the best job of providing this information to their entire community. The Air Force made those community cards initially and gave them to every single airman and every single airman's spouse. They also did training for support workers like clergy and for security officers, their first responders, and their primary care and teachers as well. So we know we need to screen. We know we need to screen because we know that almost half of people who die from suicide see their primary care doctor in the month before they die. And 2 out of every 3 adolescents who have made suicide attempts will come to the ER for a non-psychiatric reason. And so we have vital opportunities where if we were screening on a regular basis, we might find these folks before it's too late. And we know screening programs work. A meta-analysis showed screening results in lower suicide rates in adults. Elderly primary care screenings have been shown to increase detection and diagnosis of depression. High school screenings do a better job of identifying students with mental health issues than relying on counselors to go out and find them on their own. And a college screening project suggested that screening, even anonymously, where you don't find out which students had the high-risk answers, actually made it more likely that students would come to counseling when they needed help. So we can prevent suicide. We can prevent it with treatment by psychopharmacology and psychotherapy and by educating someone on means safety. But first we have to identify who needs that type of service. And the problem in the field of medicine for many years was that we didn't have a common language for how we talked about suicide. And you would see the same exact suicide behavior, and it would be called 6 different things by 6 different providers. They would call it a suicide threat or a suicide gesture or a non-serious suicide attempt or parasuicide. And we didn't really have a good idea of how much risk any of those things had. We also couldn't compare what was going on in one hospital to another when we were using different nomenclature. And so the Columbia has come along and done a big job in providing this common language for how we talk about suicide. It was developed about 11 years ago as part of an NIMH study to look at adolescents who had made suicide attempts and what was helpful for them when they were discharged from the ED. And it was done here at Columbia and at University of Pennsylvania and University of Pittsburgh with lots of experts in the field. Since that time, these questions have been used, many multi-millions of times. It's available in 140 languages, English and Spanish. You can download off our website, but if you need another language, we probably have it. Just get in touch with us. It's considered the most evidence-supported suicide risk measure. And is used across all age groups, from kids as young as 4 and 5 on up to the elderly. And the definitions that the authors of the Columbia came up with are actually now the accepted definitions by the Centers for Disease Control for all suicide research. And in their document for researchers, they don't just have the definitions and a link to our website, but they also have a list of unacceptable terms that we should stop using. Things like parasuicide and manipulative suicide act, things that have judgment about them, but also things like completed suicide and successful suicide. You complete a project and you're successful at your job, and we want to take positive words like that away from suicide. So, and also things like committed suicide. Survivors who have lost a family member to suicide tell us that when we say committed suicide, it makes them feel like they committed a crime. And so our recommended language is now to just say someone died from suicide or somebody ended their life by suicide, but to keep all kinds of descriptive language out of talking about this issue. Now, Centerstone is the nation's largest provider of outpatient behavioral health care in the country. They operate in 4 southern states, and they were one of the first agencies to embrace a zero suicide model. And what that model included was screening every single client at every single delivery point. So if you came in and had a case manager and then a medication appointment and then a group therapy, you would get screened 3 times that day. And they just make it part of their normal conversation. They tell people, look, everybody's going to ask you this because our most important job is keeping you alive. And their patients have been accepting of that. Then if they score high risk, they get placed into a suicide-safe pathway of care where the color of their name changes in their electronic health records, so every provider knows that they're on that suicide-safe pathway. They get means safety education and a safety plan. And if they don't show up for an appointment, they have a dedicated social worker who does phone follow-up to continue to reassess them by telephone and to encourage them to come back into treatment. And they actually reported after 20 months of this system that they reduced suicide rates of their outpatients by 65% over prior years. And that's why this is the model that the National Action Alliance for Suicide Prevention has as their zero suicide model for healthcare. So it was designed after doing a study of suicides here in New York, but it is now screening with the Columbia and safety planning are 2 big components of the zero suicide model for healthcare. And you can find that simply by Googling zero suicide, and you'll see all the steps that you need to take. So let's talk about the scale itself. It's simply an assessment of ideation and behavior. Ideation includes 5 questions of increasing severity from a wish to die to an active thought of killing oneself with plan and intent. And then it asks about behaviors. And for behaviors, all relevant behaviors for the first time are assessed. You know, it used to be we just asked about past suicide attempts. And when that's the only behavior you ask about, you miss the person who was practicing tying a noose or who went online and investigated ways to kill themselves. Things that we know now have just as much risk as someone who has already made an attempt for someone who's going to make an attempt in the near future. And the scale has standardized questions and definitions and examples of these types of behaviors. It's a semi-structured tool, which means that you can use the probe questions right off the form the way they're written. But if you've done this a lot and you're comfortable with it, you can make them more conversational and make them, you know, feel more like they're your own. As long as you're gathering the right information to then go back and say, yes, they had this, then no, they didn't have this. And we know that using a structured tool like this does a better job of identification than relying on just standard psychiatrist evaluation. Now, one additional aspect of the Columbia that's very useful is that you can use multiple sources of information. So if somebody can't or won't tell you the answers, you can use the information given to you by a family member or a caregiver. You can use the information that you might get from a peer, from past medical records. This can be very helpful for very young children who most of the time the parents will be the ones telling you what they saw and heard. It can also be very helpful for adolescents who may not give you the same information that their parents or caregivers give. It's also why it's used extensively in Alzheimer's research, because there are a lot of levels of Alzheimer's where patients can answer the questions themselves, but when they get to a stage where they can't, the caregiver will answer for them. So the ideation section looks like this. It's 5 questions. Have you wished you were dead or wished you could go to sleep and not wake up? And then have you actually had any thoughts of killing yourself? If question 2 is no, you can skip 3, 4, and 5. But if question 2 is yes, they have had thoughts of killing themselves, then you'll ask 3, 4, and 5, which is, have you been thinking about how you might do this? And have you had these thoughts and some intention of acting on them? And then have you started to work out or worked out the details of how to kill yourself? And do you intend to carry out that plan? You can't have a thought about a method or intent to act or a plan with intent if you've never had a thought, which is why to move more quickly, if 2 is no, you can skip 3, 4, and 5. And I'm skipping parts that are not on the short screener because I believe you as primary care providers would just be using the shorter screener. But there is a longer version that gives you a little bit of additional information. And if you are interested in that, it's very easy to add those few questions to the forms. Now for behavior, we look at 4 specific behaviors. And the first behavior is an actual suicide attempt. And the definition that we use and CDC and Department of Defense now uses is that it's a self-injurious act undertaken with at least some intent to die as a result of the act. And there are 3 important parts there. The first is that it says self-injurious act. It doesn't say self-injury. There doesn't actually have to be any physical injury for it to qualify as a suicide attempt. So if somebody puts a gun to their head and the gun fails to fire, as soon as they pull the trigger, it becomes an attempt because there's potential for injury. Secondly, it says at least some intent to die, where some is the important question. As long as a little bit of someone wants to die when they do what they did, then it qualifies as an attempt. And often people will have mixed motivations when they make suicide attempts. So sometimes if you ask somebody, were you trying to kill yourself when you did that? They might say, well, not so much. I was, really trying to just get people to pay attention to how miserable I am. But if you ask after that, did any part of you just a little bit even want to die when you did it? Oftentimes they'll say that a part of them did want to die. And then finally it says as a result of the act, meaning that the intent to die and the behavior have to be connected. They have to be engaging in that behavior because they want that behavior to end their life in part. Now, on the Columbia, you can infer intent, and we can do that in 2 different ways. The first is that if someone denies they have intent to die, but they know that what they did could kill them and they did it anyway, it can be called a suicide attempt no matter what they say. And then finally, if there are clinically impressive circumstances, that's where if what somebody does is so obviously lethal, like they took 200 pills or set themselves on fire, you can call it a suicide attempt if, any logical person would, call it a suicide attempt. So, of course, the attempt begins with the first pill swallowed or scratch made with a knife as soon as there's potential for injury. And the reason why we're really trying to find out about suicide attempts is because a very close behavior to suicide are non-suicidal self-injuries. Non-suicidal self-injury is where somebody intentionally hurts themselves, and it's 100% for a reason other than ending their life. It's usually for one of two things. It's usually either to affect the way they feel on the inside, so they're feeling pain and hurt, and cutting or burning their skin distracts attention from their internal pain, or they are feeling numb inside, and those self-harm behaviors release adrenaline, which makes them feel present and alive. Or to affect external circumstances. That's the person who pretends they're suicidal because they want attention, or they want to get into a hospital bed because it's cold and they're homeless and they need a meal. Now, this is what on the full version the actual attempt piece looks like. It has multiple probe questions to help you figure out if there was an attempt. I'll show you in a second what it looks like on the short screener. But the other three behaviors are an interrupted attempt. That's when somebody takes steps to end their life, but someone or something stops them before they actually do anything. Someone who's got a bottle of pills or a gun and someone grabs it from them. And then a self-interrupted attempt. That's when a person begins to take the steps to end their life, but before they actually do anything, they change their minds, they stop themselves. That's the person who's planning to drive his car off of a certain cliff, and halfway there he turns around and comes back home, or he's climbing the stairs to a building to jump from the roof, and before he gets to the top, he comes back down. And then finally, preparatory acts or behaviors. That's any other behavior beyond a verbalization that has suicidal intent. So things like collecting the means that you'll use in a suicide attempt, giving away your valuables, writing a suicide note. And, we think that by asking about all types of ideations and behaviors, maybe we'll find kids like Dylan Klebold, one of the Columbine shooters, who mentioned suicide more than 5 times in his journals, saying things like, "I don't fit in here, and thinking about suicide gives me hope." Or even as recently as the Santa Fe shooter, who wrote in his journals that he wanted to kill people and then kill himself. Now, all of these behaviors are important to find out about. Because the 3 behaviors that we never used to ask about, the interrupted attempts, the self-interrupted attempts, and the preparatory behaviors, actually happen more than actual attempts. So this is a look at almost 30,000 screenings with the Columbia. And when they did that, they found 87% of the worrisome behaviors were these other 3 behaviors, and only 13% were actual attempts. So if all you ask about are past attempts, you're going to miss the vast majority of these worrisome behaviors and people who are at risk. So for behaviors, you want to ask about all of the behaviors. You want to find out about behaviors that are part of discrete episodes. So if somebody, did 3 preparatory behaviors and then made an attempt right after that, you wouldn't count that as 4 separate things. You would count that just as the one attempt. It's also important to listen to what the person believes is going to happen from their behavior and not what we think about lethality. This is really important for very young kids who may do some things and say that they're killing themselves, but we know that those kinds of things won't really kill them, like putting their head inside a pillowcase. It's also very important for folks who might be psychotic and may come up with some strange ways to kill themselves. We had a girl hospitalized here at Columbia who had made some serious suicide attempts. She was a psychotic adolescent girl. And she also made one suicide attempt where she ordered so much Chinese food because she believed that she could eat herself to death. And so, she, in her psychosis, thought that that was a way to kill herself, and that's what she tried. So we need to, listen and call that an attempt. So here's what the screener looks like. It has all 4 of those behaviors combined into a single question, question number 6. And it says, have you ever done anything, started to do anything, or prepared to do anything to end your life? And that gives you a lifetime assessment of their behaviors. And then it says, if yes, was any of this in the past 3 months? And we're going to talk right now about why the last 3 months. So when the authors were developing the scale and collecting all the initial data, they determined that after 1 month of thoughts and after 3 months of a behavior, the risk for making an imminent attempt drops dramatically to the point where we're not going to call that high risk. So you're asking for those first 5 questions about the past month, and you want to know about their behavior for the past 3 months to determine current risk. And we really believe that we need to monitor this. So just like Centerstone is asking every client every time they see them, we believe that everybody should do that. And so we have a version of the scale that's called our frequent since last visit version, or since last asked version. And so it frames all of the questions as since you were last here or since we last asked. And again, is a way for you to monitor after you've done an initial screen with someone. So what do we worry about? Those high-risk answers. Those high-risk answers are the answers that are colored red on our triage screeners. And so those are questions 4, 5, and 6. So the difference between 3 and 4 is if someone says yes to question 3, they're saying, I've thought about hanging myself before or driving my car into a tree, but I would never do that because I have family that depends on me, or you know, I have things to look forward to, I have a reason to live. When they get to a 4, it's where they say that they had intent to do it, or they currently have intent and a plan. So if they've had intent to act in the past 1 month, or they've had any of the 4 behaviors in the past 3 months, that's when they score as a red high-risk alert, and the next step is absolutely necessary, which includes keeping them safe with a one-to-one until somebody with behavioral health experience can reassess them and make a determination that they don't need that anymore. And so wherever they're using this, the spouses in the Air Force, the primary care doctors, the Air Force medical screeners, they all have the same high-risk answers. The high-risk answers never change. High risk is a yes to question 4 or 5 or 6. What changes are the next steps you take, because if you're inpatient, your next step will be different than if you're in a jail. But no matter what, the high-risk answers are the same. We also have a checklist of risk and protective factors that you're welcome to use. These are things that someone might have going on in their life that increase their long-term risk, but they don't tell us about their imminent risk. So things like any kinds of losses they might have experienced, family members who have died from suicide, any mental health issues or diagnoses that they might have, any substance abuse problems, and for protective factors, do they have a reason to live? Are they engaged in work or school? And so, for example, you can mix and match all of our tools. And so Tennessee, for all of their crisis assessments, have chosen the short screener with 6 questions and the checklist of risk and protective factors, because they said that if on their crisis call, if they can't really determine from the 6 Columbia questions whether they want to take someone to the ER, they would like to know all of those risk and protective factors as well to help inform their clinical judgment. We also now have an app for the Columbia questions. So if you go to either the Google Play Store or the Apple App Store and search on Columbia Protocol, our app will pop up. It's free. It guides you through the 6 questions and then will give you a possible risk category based on what answers are yes or no. And this is actually already having a strong impact on care delivery and service utilization because we're asking better questions than we used to. you may be familiar with the PHQ-9. The PHQ-9 is an excellent measure of depression. Was designed to follow the DSM depression diagnostic criteria, and it does a good job of assessing depression. But it does a poor job of assessing suicide. The suicide question is thoughts you would be better off dead or of hurting yourself in some way. Now, better off dead is not considered suicidal by suicide researchers, and hurting yourself in some way can be non-suicidal self-injury. So Cleveland Clinic took a look at 523 patients in their outpatient program and used both the PHQ-9 and the Columbia, and they found that almost 24% said yes to item 9 on the PHQ, and just 6% then had a positive screen on the Columbia. So they had, about 3 times as many false positives as they needed. So if you are using the PHQ as your first screen and then adding the Columbia after, you will have much more work than you need to do because of the false positives. We recommend, if you want to assess depression, to use the PHQ-8 questions, the first 8, and then use the Columbia screener instead of question 9. And this is what happened at Reading Hospital after they started using the Columbia. They reported out that their one-to-ones and psych consults in their emergency department always maintained at a lower level than they had been in the time prior to using it. And Centerstone actually just reported to us recently that they reduced their emergency department recidivism rates of their outpatient clients from 40% to 7%. Again, because they're only sending the right people to the ER. And, sending the right people to the ER has always been a difficult thing for schools because they err on the side of caution and care about their kids. But what ERs in New York said was that, most of the kids the schools are sending us don't need that. They don't need the level of care that a ER evaluation provides. And in fact, for kids and adults, when you have an ER evaluation and it's not necessary, it actually shuts people down to getting care when they do need it. If the first time a student says that they're wishing they were dead, they get sent to the ER where they sit for 6 or 8 hours. Their parents get called. Their parents are mad, and they are sent home because they're not high risk, and they're in school the next day. It's not likely that they'll say anything the next time. And so we're really encouraging not just schools, but everybody to just send the right people to the ER, those folks who have that high risk answer of 4, 5, or 6 on the screener. And so every school nurse in New York City now knows how to use the tool. Every teacher in Israel has a copy of the scale. We've worked in many, many school communities to provide these questions to both counselors and teachers for identification in their classes. Now, a lot of people worry if we start screening everybody, aren't we going to find a lot of people that need help? And the answer is that I promise you won't. This is a look at 3,000 veterans that were seeing a psychiatrist. So they're a high-risk group, vets with a mental health problem. And when they screened 3,000 of them, they reported back to us that they found just 0.5% or 14 of them that needed follow-up. And of those 14, 5 of them were hospitalized. So again, less than 1% had these high-risk answers. And Parkland Hospital is the first hospital in the nation to do universal screening with the Columbia. So every client, patient that comes in for any medical reason is getting screened with the Columbia. And they reported out after their first 100,000 patients were screened that they had 1.8% that needed follow-up. And so they have 12 psychiatric social workers that do that follow-up with that 1.8% that they're finding need someone to ask some more questions. And again, just about everywhere we see it's under 2%. It's usually 1.5% that will have these high-risk answers. And people worry a lot about liability these days. We have a very litigious society. And so Crain's Magazine did an article on the Columbia, and they interviewed medical malpractice attorneys. And those malpractice attorneys told them that if the Columbia is the gold standard, which it is, and you're using it properly, that's the most support that you can have. That's the safest you can get. You know, where people get into trouble is where they're doing nothing, or they're asking questions they made up or that were there when they got there. You never get in trouble for asking a scientific question and then following the recommendations of the authors of the scale. And, you know, we believe that just talking about suicide, just having a conversation like this, just looking at one of these community cards, being handed one, actually is an intervention in and of itself, because it breaks those barriers to talking about suicide, builds this common connection through language, and actually, you know, can help to fight the loneliness that suicide and depression often have with them. So you're welcome to reach out to us at the Columbia Lighthouse Project. You can do that by writing to Dr. Kelly Posner's email address, kelly.posner@nyspi.columbia.edu, or just go to our website, cssrs.columbia.edu, and there's a Contact Us page there. You can also download all of our forms, all of the screeners, the longer form, the checklist of risk and protective factors, examples of them being used. You can look at training demonstration videos, both there and on our YouTube page, but plenty of ways for you to find out a little bit more information or get the tools that you might need to be able to use the Columbia. So I'm happy to answer questions for the next few minutes. I do want to respect, though, that it's Friday afternoon and your time is all valuable.
Thank you, Adam, and thank you to everyone for attending today's webinar. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you can complete that and provide your feedback. On behalf of the Nevada Primary Care Association, thank you for joining us today and have a great rest of your day.